Neither the El Paso County Medical Society, its members, nor KCUS-TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Challenges of the colon. That's what we're talking about tonight. What is irritable bowel syndrome, IBS? We've heard about it on many TV commercials. What is diverticulitis? How do you know if you have polyps in your colon, and how do you know if those polyps are dangerous? These are all issues with the digestive tract, stomach pain, cramping, chronic diarrhea, all kinds of stuff. We're talking about the pooping process tonight, no kidding. And it's going to be a fun show because we know we all have these issues. During this next hour, we have experts answering questions about colonic diseases, everything you've ever wanted to know, but we're a little bit too embarrassed to ask. Now is the time to ask. As you know, this is a live show, to stay tuned with us and give us a call at 880-0013, a lot of zeros there. So 880-0013. And also, we are streaming live on Facebook, so you can ask your questions live on Facebook as well. Just find KCOS TV and then find the El Paso Physician. But again, it's live, so it will just pop right up on your phone and or your computer device. Again, questions are live. We want to say thank you so much to Lachlan Vo and also Heather Jones, who are here from the Texas Tech School of Medicine, and they are here to answer the questions on the phone, or actually answer the phones, and the questions come our way. And we also want to say thank you so much to Dr. McCullum, who is underwriting this program along with the Texas Tech University Health Sciences Center, and for the El Paso County Medical Society, who has been sponsoring this show for 22 years. I'm Catherine Berg, and you're watching the El Paso Physician. Good evening. Thanks again for joining us. One of my very favorite docs is next to us right here, Dr. Richard McCullum, who he calls himself very endearingly the tummy doctor, and I think that's fantastic. He's technically a gastroenterologist. All three of you are, which is kind of nice, but we're going to talk about the different disciplines that we have within each one of your disciplines. We also have Dr. Sherry, and I like this, Moraveggi. And I said, okay, how do I pronounce your name? Moraveggi. I'm like, that's great. So very healthy, right? Yeah. And then also we have Dr. Antonio Mendoza Ladd with us. Again, all three gastroenterologists. But Dr. McCullum, you know the drill. So What we also like to do at the beginning of the show is let the audience know who you are, that you guys are human, which we love, and what it is that you do all day, every day. I know you've got a bunch of different titles and things that you do, but just to kick off the show, if we can start with you.
Well, thanks. First of all, we're glad to be with you, Catherine, because you're sort of the queen of GI, if you like. You've had us on this show many times. So I'm a gastroenterologist, look after the tummy, the esophagus, the colon, the pancreas, the liver. We cover all those bases, including nutrition. But on a given day, I'm probably found most often seeing patients in the clinic, trying to do some research, looking at new angles and new tests and new treatments for the GI tract, particularly for nausea and vomiting and problems with digestion. And at the same time, I try to administrate a little bit as far as covering national activities and national affairs. Mm-hmm. But I'm in very good company here with a great GI group, and I'm glad we invited Dr. Moraveggi and Dr. Ladd. They'll tell you more about the day-to-day workload that they do, which keep the people of El Paso in good health.
And thank you for that. Thanks for keeping us in good health. I was joking a little bit tonight. My real job is the El Paso Community Foundation. We have a gig going on over there, and I said, hey, I got to go do my show about the pooping process, because we joked about that the last time we were here. And so the reason I say this is that this is a medical show, and sometimes it's really difficult to talk about things that are uncomfortable to talk about things. So we try to keep things, again, very comfortable. Dr. Moraveggi, you're the first time here, and you've got your notes, and I want you right now to show the world your notes, and I'm going to show the world my notes. No, just do it. Just do it. No. Because they need to know.
It's secret.
No, because you've got like highlights on there.
I'm sorry. That's a secret. Sorry.
I love it.
Sorry.
But what do you do all day, every day?
So I'm Dr. Moraveggi. I'm a third-year GI fellow at Texas Tech. And I'm in my last year of training. I got 4 months left to finish. And what we do is the same thing that Dr. McCullum does. We see patients in the hospital that have anything from lower GI bleeds to upper GI bleeds, any liver issues, cirrhosis, Crohn's disease. We see outpatient clinics that we get overseen by our 2 attendings here, and we do endoscopies all day as well. So
Okay.
upper endoscopies, colonoscopies. Dr. Ladd specializes in ERCPs and endoscopic ultrasound, which is a little bit more specialized.
Okay.
That's about what we do every day.
And Dr. Mendoza, I get to say this because Dr. McCollum said that you do therapeutic endoscopies, and I thought, can they be therapeutic? It's funny to have those 2 words go together, but what exactly does that mean, if you explain that to the audience?
So therapeutic endoscopy means that nowadays we're not only able to diagnose you. In the old days, we used to put the camera in and we can diagnose you, but there was very little we could do about those things. Nowadays, there are many, many techniques and devices that we're using through the cameras that we use to remove lesions, to treat bleeding lesions. There's a variety of things that we can do. So therapeutic endoscopy deals more with what we call it interventional stuff.
Nice, okay.
Meaning we can cut, we can suture, we can cauterize, we can do all sorts of fun things while we're doing the procedure.
And I'm going to come back to you and Dr. Moraveggi in a few moments because we're going to talk about some numbers. But I love that because we talk about, every time we do the show, that the digestive tract is one of the most preventative cancer types that you can get because you can go in and take care of things while you are trying to figure out what the diagnosis is. So very important. And Dr. McCollum, if we could, I love starting off the show with kind of describing what we see up here so that as we're talking, what exactly is it that we are talking about? This is which...
Sure.
So we've got the rectum down here, we've got the small intestine, large intestine, we've got the stomach, we have the esophagus. Just go to town on all that good stuff.
Well, for our audience out there that are having dinner maybe in a minute or maybe eating now, we're going down your esophagus into your tummy, which is actually a very small part of the abdomen, only about 1 foot long, 20 feet of small bowel, then take care of digesting your food, and then the waste material slowly evolves down 6 feet of colon into your rectum. And so we're talking today mainly about the colon because this is Colon Cancer Month, March, and we're going to bring to your attention all the things that we can do to help you out there. And I'm going to be talking about some other entities that mainly involve the distal 6 feet called the colon. But indeed, there are 20 feet of small bowel and 6 feet of 1 foot of stomach that we have to keep in mind when you come to us with your symptoms. But we're going to focus today on the colon.
Okay, excellent. And on that note, Dr. Moraveggi, you were just talking about, so in the old days, I'm 52, but when I was 49, for the sake of the show and saying, hey, I'm going to get my colonoscopy, now we're looking at numbers in ages that are younger than 50 to have your first colonoscopy. Maybe you can kind of, if there's a reason why, explain that. If not, just maybe go through the new screening guidelines.
So the colonoscopy used to be starting age 50 to 75 years old.
Okay.
And you do it every 10 years as long as it was normal. You could go above 75, but it depends on how the patient is. Is the patient active? Is it a 76-year-old that's like a 55-year-old? Or is it someone that's physical status isn't good?
Okay.
Recently, just about a couple months ago, they decreased it to 45 years is where you start doing the screening colonoscopies.
Okay.
I think the reason being is that they're finding more cancers in younger patients now. Many reasons being, as what I read, was obesity is one reason and the inflammation that it can cause, but that's what the age is now, 45.
Okay.
So that's what we started implementing just a couple months ago.
And I probably read too much before these programs, but our diets have changed significantly in the last several decades in just the processed foods, et cetera. So that might be something too. And Dr. Mendoza, this is a perfect transition to you because with colonoscopies, because we do want to focus on that this evening, you were beautiful in the way that you said when you're going in and doing endoscopy, what is it that you would commonly find that you would remove and how would you remove it? And also, however you want to take a case study of maybe a super clean colon, but maybe there's one tiny little polyp, I'm not sure, should I take it off, should I not? Explain what it is that you are thinking when you're going through a colonoscopy.
When we're doing a colonoscopy, we first of all need to make sure the colon is clean enough so that we can find things. The main purpose of a colonoscopy is to find removable precancerous lesions, also known as polyps. Polyps come in a variety of sizes, a variety of shapes, a variety of different things. We basically look at the way they look. We use all sort of fun stuff to look at them. We can do a zoom into the tissue of the polyp. That gives us a little more information about whether this may be malignant or not. We look look at the shape of the polyp. We look at how deep into the wall of the colon is. We also need to know if it is really resectable or not. There are criteria that we use to know whether we can cut this out or not.
And if we could, while you're speaking, if we can go to slide number 1, Mario in the back, and we might be able to show the audience a little bit of what we're talking about on the screen. It would be here, but I think they'll be able to see it better right there. Are you able to see that and describe? Yes. Okay, excellent. So if you can continue.
So if we were to start from the rectum, which is where we normally see for the first time when we put the camera in, and we go all the way to what we call the cecum, which is the junction of the small bowel and the colon, you can see in that diagram there are many things that are illustrated. Number 1, diverticuli. Diverticuli are little pockets that form in the colon, and just as part of the normal aging process. Our diets have a lot to do with that also. They're, for the most part, benign, except that sometimes they get angry and they bleed. And when they bleed, they can bleed quite profusely, and we need to intervene on those sometimes. Then we have polyps in that picture, and those are the lesions that we are looking for when we do a colonoscopy, and we resect them in a variety of ways. We have little forceps that we can use to take them out. We have metallic sort of like lassos to cut them out. Sometimes we need to aid ourselves with electricity around that lasso to cut the lesion out. Sometimes if the lesion is too deep, we need to raise it and separate it from the rest of the layers of the colon. The colon has basically 4 layers. And we have to make sure that it doesn't, if it is too deep and we cut it all the way out, there is a risk we can make a hole in the colon.
Right.
So to avoid that, we use some substances to separate that lesion from the rest of the walls so we can cut it out safely. And let's see what else we have here. Diverticulitis, which is something that gets very confusing for people. Diverticulosis does not mean diverticulitis.
Yeah, well, you know, and I just learned that today while I was practicing our fun. And I'm gonna stop you there because otherwise we'll go all the way through. And you may have mentioned it, but I was reading something else here. The cauterization that happens. So once something gets clipped off, maybe you can explain to the audience that it's not just then left a bleeding wound or what have you. Maybe you can describe what it is that you do once something gets clipped out.
So once something gets clipped out, we can cut it out without electricity and with electricity.
Okay.
It all depends on what the lesion looks like. When we do it without electricity, we cut it out. There is some minor bleeding, but it eventually stops unless you have an underlying bleeding disorder that then we need to address before we do your procedure. When we use cautery or electricity, that electricity basically cauterizes, literally.
And just burns
wound, and so it burns the area where the polyp was, and that automatically makes the bleeding stop.
Excellent. Thanks for saying that. Again, I was asked to give out the phone number again. 881-0013 is the phone number. And again, we are streaming live on Facebook. I know we've got some questions coming in already. And because now I'm curious, because I had in my opening statement that there's diverticulosis, which could turn into diverticulitis. So, Dr. McCollum, you said everybody after 40 has diverticulitis. No, has diverticulosis.
That's correct.
So I've got diverticulosis. What in the world do I have?
This is just wear and tear. This is arthritis of the GI tract. You're squeezing every day, pushing that poo-poo out.
Right.
And it gets a little bit tired, and little crevices or little pockets develop called diverticulosis, as we saw in the screen.
Gotcha. Okay.
The good news is that only 5% of people, of all of us, will ever get one of the complications.
Good.
Diverticulitis, where you get inflammation and pus, if you like, an abscess develops, and you could actually end up requiring surgery or could heal by antibiotics and time.
Okay.
Another subset might bleed and have a very active loss of blood through the rectum, painless.
Painless.
Classically
you don't
painless
know you
bleeding.
have it. Okay.
No pain. Just suddenly happens. Over the age of 45, a sudden bleed like that, diverticulosis, bleeding would be the first diagnosis you'd think of.
Now, this is going to go into the gross questions, but how does one know if you have blood in the stool? If we can describe what the stool looks like, if you're bleeding or not, because unless it's dark red blood, I mean, that would be obvious, but that's not always the case.
We have the fire engine red,
Okay.
which I think we can figure out.
Right.
There may be subtle streaks mixed in with the stool
Okay.
as it comes out, not on the toilet paper, that's more hemorrhoids.
Exactly.
We're talking
so
mixed
I
in.
guess we're telling people to look back
Mixed
and
in.
see what's in there. Right.
And then you may see a very dark colored blood.
Okay.
Sometimes with a very specific odor. And that may have come from much higher up, maybe the right side of the colon, or even higher up in the intestine. That's called melena.
Okay.
M-E-L-E-N-A, melena. That's a darker black-looking stool,
Okay.
as opposed to a metachesia, a red stool. And there are important differences. And but most patients will see that they're feeling weak, something's going wrong with their stools, and they'll call it bleeding. They'll probably figure that out.
Okay. And see, on that, and Dr. Moraveggi, just because you're there and you get to do all the studying, we were talking about there could be bleeding happening and going on and have no idea that it's happening. So if someone were to be looking for symptoms, what might they be looking for if they have a problem? Dr. McCollum just said weakness, maybe because there's a loss of blood, but just in general, if you're 45, 55, 65, never had a problem, don't know that you're bleeding, how does one know? Maybe I should get that colonoscopy like that TV show said.
So there's symptoms such as fatigue that you can get because you're losing blood, you get anemic. But usually lower GI, even if it's going to bleed, it usually doesn't bleed that significantly.
Okay.
But it can show up with an anemia. When usually patients with lower GI bleeds are the only symptom that they have is they come in and said, I have red blood or I have tarry stools, but they don't have typical symptoms of anemia.
Okay.
Unless the colon cancer has been there for many, many months, and then they'll come in with, usually it's fatigue.
Okay.
Anemia can give you a little bit of an increased heart rate. You may get short of breath if you're exercising or walking up some stairs.
And anemia you can find out through a blood test just to kind of see.
You just get a CBC. They're like, hey, I'm tired. I don't feel up to par. The same activities I did a couple months ago, I don't feel that great. And then, if they have a colon cancer and it might be bleeding slow, they may say, I have decreased appetite, I have weight loss.
And pardon my ignorance here. So sometimes when, for example, when someone's about to faint, it's like the color leaves them. Is that something that you can also, you just feel like you're feeling pale, or somebody says, man, you've been looking pale for the past couple of days. Is that something?
Yeah.
Or, okay.
Yeah.
All right.
And also change in bowel habits.
Okay, nicely
There
said.
could be a change in bowel habits, a looser stool or a more difficult stool. Both could correlate with seeing some kind of change in color as well.
Okay.
If I may add
Dr. Mendoza, yes, I had another question.
One interesting symptom that patients may notice is what we call pica. Pica is a tendency to try to eat non-edible substances. The most common one, even though by definition it doesn't really fit the definition I just gave you, but one of the most common we see is people crave ice. For whatever reason, anemic patients come to clinic and say, recently I've been craving ice out of the blue. I've never had this cravings, and now I have them. Another more interesting and a little more bizarre one is people tend to eat
soil.
dirt.
Yeah, I've heard of that
And,
before.
and
Okay.
that's we don't really see that much anymore, but I guess in the old days it was very common because we didn't have all the stuff we have now to diagnose you early.
Right.
So that's just another interesting symptom patients can get from being anemic.
I hate to say, I was one of those kids that loved eating. My mother was a gardener, and the fresh soil from the bags, it smelled so good. I should stop there. While we're talking on this subject, and I know we are not concentrating on the stomach at all, but what can an ulcer do when it comes to symptoms that may mimic, or is it completely different than if there are issues with the lower tract?
Ulcers, Catherine, we're talking more, I've got pain up here, doctor, just below my ribs, what's called the upper abdomen or the epigastrium. It's more of a burning, penetrating pain, particularly at night when I'm fasting and there's no food to cover or protect the lining of my stomach, the mucosa. The acid burns through and develops a little hole called an ulcer. So I'm going to have a burning upper abdominal pain. I may have some black stool called melena. I may be bleeding. And eventually I could even be nauseated because I may have blood in my stomach, and that makes me feel like I could even vomit.
Okay. And I wanted to say that because I knew that there's always questions about, and again, I know I was joking, but don't be afraid to look back and see what's left. I don't know how to say that nicely, but it's just one of those things. Irritable bowel syndrome. I feel like I want to talk about that because I feel like that's so vague.
Yes.
And you hear about it all the time, and there's all kinds of medications over the counter and everywhere. I'm going to throw this out because you just talked, Dr. Mendoza, you get irritable bowel syndrome. What is irritable bowel syndrome? And I know we can talk like 8 hours on that.
Oh, way more.
But
than
when we talk about, we're watching a TV show or we're watching, you know, something on the internet, and boom, there's something about irritable bowel syndrome, and you're like, oh, I've got that. I had diarrhea last week. Oh, wait a minute, I have that because. Explain to people what that is and when you really would have a problem versus an occasional bout of something.
All of us get diarrhea or constipation every once in a while. That's part of life. But irritable bowel syndrome is basically a condition that is characterized mostly by persistent abdominal pain. That's the underlying persistent symptom, the sine qua non of IBS is pain. This pain has certain characteristics. One of them is the fact that it may get better. It actually, most of the time, it gets partially better by having a bowel movement. Regardless, it is a hard, difficult to pass stool, or is it a diarrhea, loose stool. People say, you know, I get this terrible cramping once I go to the restroom and I pass some stool. It goes away partially, not completely, but I do feel a little better.
So it's still a chronic condition.
It is a chronic condition, and it is associated with also alternating patterns in your bowel habits. Some people, we classify it as IBS-C, which means predominantly constipation type, IBS-D, predominantly diarrhea type, and IBS mixed, which is a combination of both.
Okay.
And we have all sorts of fancy criteria to diagnose you with one of the three sometimes, and that's why IBS is such a challenging condition. It's not like, I like Dr. McCallum's quote, it's not a cooking recipe.
Right.
Everyone has a different flavor, a different style, and it requires very subtle fine-tuning and a lot of knowledge to be able to make an accurate diagnosis and treat you appropriately, because everyone is going to need an individualized, personalized treatment that may not fit the next patient that walks through the door.
Okay. And so here when I was in college, I dated a boy who his mother said, oh, he has a nervous stomach. He's always had a nervous stomach. Is that kind of what we're talking about? Is it something that nerves play a part of it? Obviously, genetics play a part of it. Food plays a part of it. Is there a cause for irritable bowel syndrome?
Do you have that slide?
Yes. So there's a photograph. The photograph that we're
The
looking at.
The photograph.
Okay. So it's the second slide.
Dr. Mendoza lad covered it very well. I'll put on my neurogastroenterology
there we go.
hat.
Look at there. Lovely.
No, not that one. That's the diverticular.
Oh, the first one?
Keep going back a couple slides. A couple more.
Actually, I think there's only two.
I thought I sent you more.
We only have two. So might there be
well,
something up here?
neurogastroenterology-wise, irritable bowel is really a great marriage of the brain and the gut, Catherine, because stress and anxiety in life do provoke and worsen the symptoms, lower the threshold for pain, and seem to promote encounters every day where you feel pain that's relieved by a bowel movement in some cases, and in other cases the pain is not relieved until you take an antispasmodic or some other medication. Now, it's a daytime problem. So after midnight, when the colon goes to sleep, relatively speaking, your bowel is at rest.
Interesting.
But during the day, you're eating, provoking a very sort of fidgety, upset GI tract, colon, and you've got the effect of stress, daily life. So that combination promotes a GI tract, particularly the colon, which seems to be sensitive to pain and has different bowel movements.
Okay.
And as we talked about a little bit, you said, what's the cause of it? Many patients come to me and say, gee, Dr. McCallum, I'm in your office, my sister's at home, my mother's happy, what happened to me? And basically the two main theories is that you had a gastroenteritis illness, food poisoning or an event. May not remember it distinctly, but it attacked your neuromuscular mechanisms, your leaky junctions developed, antigens got into your mucosa, and you rearranged your microbiota.
Right.
The bugs in the gut are unhappy. They're out of balance. And that's thought to be the newest and most endearing theory. On top of that, stress and a stressful life may lower your threshold for pain and make you more prone to feeling that the pain is unacceptable. So in a nutshell, it's It's the brain, the gut, infection, microbiota, and sometimes the food we eat can promote gas and bloating, which tends to worsen our symptoms and make us feel even more uncomfortable.
Dr. Moraveggi, because you're the kid on the panel, right?
Yes,
you're the young
guess.
one. A decade ago, when you were just in diapers, we never heard about having to take, probiotics or prebiotics, and it's like the last decade-ish, I'd imagine, when I feel like that's exactly what you're talking about.
Got it.
So since you're young and you've had this around all your life, the idea of this, what in the world is a probiotic? What is a prebiotic? Why is it such a big deal? It's not that it's just now being discovered, but it's being marketed now. I don't even know exactly what question I'm asking, but let's go with the probiotic. What is happening physiologically in your gut when your doctor asks you, and if you need to throw this to someone else, do. When your doctor asks you, hey, you need to start, you guys are cracking up. You should get a cross shot of all three of them right here. What's happening in your gut when you're being told to take a probiotic?
Okay, so normally there's bacteria that live in your gut, and
that's gross in and of itself. Not anymore, but when we first heard about this about a decade ago, it's like, what?
Well, no, I mean, there's a whole bunch of stuff growing on our skin. There's a whole bunch of stuff living. So the way that our body functions is that normally you need healthy bacteria in your gut in order to function appropriately. You want a certain number of bacteria. You don't want more than that. You don't want less than that. So probiotics are basically stuff that you can find in yogurt. There's certain names that they have. And basically these bacteria help keep and maintain a healthy gut for you, so that you're not producing too much gas, you're not getting bloated with some certain foods that you eat, and that's basically what I know about it. And if anybody else would like to add, they may. Okay,
Dr. Mendoza, you're an old man. Not that old. But, so someone who doesn't have any issues, any symptoms, and they're that person that at lunch they bring out the vitamin case, and there's 20 vitamins here and 20 vitamins here. Is there a reason to take probiotics if you don't feel like you have any issues, or is it just something that's good to take just because it's good to take? And I know that there's pill form, I know there's yogurt form in general. How important is that? Do you usually have an issue before you feel like you need to take probiotics? Like a huge, if you're in the hospital for a couple of weeks or months and you've been on antibiotics for a long time, that messes up your gut. Answer that in any way that you think makes sense to the audience.
So, for a completely normal person who is asymptomatic and is not having any issues, I would have to say my take on this, and I can give you my take and the evidence we have behind it. Don't take them.
Okay.
The old saying goes right. Don't fix it if it ain't broken. So if you're fine, you feel good, there's no real need for you to take it.
Gotcha.
Now, going back to what you said in the last decade or so, all this being promoted and advertised, and it's getting into people's psyche. One of my old teachers used to say, knowledge is only good for two things, and one is to overstress, and the other one is to fool people who don't know. So
I like that.
when you hear all about these things going on, oh my God, maybe I should be taking them, maybe there's something wrong with me. And nowadays also with the combination of Dr. Google, we see that a lot. People have a little bit of information with not a good background to use that information with. So people get confused a lot, and then they look up their symptoms and they think they have cancer, and they come into our offices saying, I need a CAT scan.
Yeah.
Because that's what Google said. So it's a little bit of common sense, a little bit of being able to have a good communication with your doctor to make sure that you're not making wrong decisions.
Right.
But just going back to the probiotics, there are studies, there's evidence showing that they may help in certain conditions. But for the average person who is asymptomatic, having a good life, happy life, don't take them. There's no need for that.
Nicely said. I'm going to use this opportunity to give out some websites and telephone numbers so that the Dr. Google isn't all that dangerous, because we really like to give out information on the show where it's peer-reviewed and medically reviewed. But we've got the National Digestive Diseases Info Clearinghouse, and that website, it's easy. It's not going to be that hard. It is digestive and then NIDDK.NIH. I will say these again when the show is over. But again, if you want to look up, search engine it, National Digestive Diseases Info Clearinghouse. If you are one of these people that watches the show over again, which you can on the web, a telephone number, 301 654-3810. Sometimes it's nice to have a voice on the other end of the line. Again, 301-654-3810. Also, there is the U.S. Prevention Task Force, and that website is basically USTPS. So again, think about U.S. Prevention Task Force, and then you can go look information up. Again, you'll be able to watch the show again several times if you'd like. I'll tell you about how to do that later. We are getting so many questions from the audience. I'm going to read this one cold. Yeah. I was diagnosed with diverticulitis, complicated by a perforation and abscess 6 years ago. Since then, I have been on TPN and had multiple fistulas. Sorry, what causes these fistulas? So that's a loaded question. Again, straight from the audience. I'm just going to throw that your way, Dr. McCollum.
Yeah, well, let's show that slide of the diverticuli, the one that we had the colonoscopy on, if you wouldn't mind.
Okay, so that would be the first slide.
Just so the patient, just so we know what we're talking about, there's a slide.
The one that's
there.
actually the photograph?
Yeah, that one there.
Okay,
so these are the pockets that you have in your colon.
Okay.
The audience does. Some are smaller than others. And you can imagine that something could get stuck in there and get infected, and you develop an abscess. And this lady had one, and it probably did not respond enough to antibiotics. He was going in the wrong direction, if you like. So the surgeon said, I'm going to divert your colon and do a colostomy and maybe resect this segment or let it heal and come back. Now, why she's had a very tough career, if you like, and that she's developed fistulas, this could mean that the abscess was left, perhaps not resected, and it has gone through other parts of the bowel and connected to the skin. And she's now leaking small amounts of fluid. Or, we don't know the diagnosis, there's a condition called Crohn's disease, which can often lead to fistulas, notoriously can lead to fistulas, and maybe this was not accusing anyone of misdiagnosis, but maybe it was missed and called diverticulitis, but it wasn't. Unusual, unless the abscess was left and it's continued to fester and cause fistulae. I think another opinion or coming to a gastroenterologist to review all this might be appropriate for that particular caller.
Interesting, and you're right. I mean, there's so many different things out there. We do also have a Crohn's disease hotline. I'll give that at the end. There's another question here from the audience, and I'm going to go to Dr. Mendoza on this one because we were talking about removing polyps. What is the significance of a 15-centimeter polyp in the pylorus? Question from the audience. Again, I didn't do my disclaimer. We get what we get, and that's all we get. So sometimes we do not have enough information from what we're getting from the calls, so that's why we had that disclaimer in the front. Nobody can get sued for giving the wrong answer. But if we can answer it, great. If not, then we can pass on it.
Gastric or stomach polyps are a little different from colon polyps.
Okay.
The good thing is, for the most part, they're benign, and we're able to resect them, and that's the end of the story. Sometimes they are associated with certain conditions that are rare, but they can happen. And the answer to that specific color that I would give is the significance lies in the pathology results. Once they took it out, the pathologist put it under the microscope, and he or she analyzed it, and he or she gave a diagnosis. Like I said, most of the times, 85% of the times, they're benign polyps. If this was not a benign polyp, then the pathology would have communicated that to the surgeon or the endoscopist who removed it, and then he or she would address that appropriately.
Okay.
But in general, gastric polyps are not the same ones as we find in the colon.
Okay. Nicely explained. Question here from the audience, and I know this is colon, but let's talk a little bit about the rectum, just because it's a question on several of these questions. And we can talk about the difference between, number one, we can describe what a hemorrhoid is, and the difference between hemorrhoids right at the end of the rectum and skin tags. So this person has been diagnosed with skin tags, but it's not a hemorrhoid, so let's just answer the question, whoever wants to take it, of what the difference is. And there we go.
Very well.
I can point it out, and you want to describe it? So the rectum is right here, and it has drainage from veins.
Just a smidge.
So You have a little line here called the dentate line, and below them you have where the sensation is in your rectum, and you have also hemorrhoids that can get above the dentate line, which are called internal hemorrhoids.
Okay.
External hemorrhoids can be painful. So hemorrhoids are just basically the veins that are draining, they get dilated. And patients such as women who give birth are more prone to this just because of the way birth is. So hemorrhoids are just, you can have them extruding out. You can have them within. Sometimes you're able to push them back into the rectum. Sometimes you cannot push them out of the rectum. Sometimes when they sit on the toilet, they will be extruding out, and it can be painful.
And there's usually pain, okay.
They can be painful because they're external. Internal hemorrhoids can bleed. Sometimes if you have hard stools that pass by the internal hemorrhoids, you'll have blood on the toilet paper after you wipe.
Okay.
And those are only visualized by a colonoscopy or an anoscopy done by a professional.
Okay.
And I'll let Dr. McCallum talk about skin tags and anything else he wants to add.
Well, skin tags are probably just a jargon name for leftover scarring from external hemorrhoids. There's really not much that we could call them. Sometimes condylomata, little pimples or papules, can scar down and cause what's called a skin tag. But those are not to be misconstrued or concerned about cancer. That's a different feeling. Sometimes patients want them removed because they can feel them when they wipe. But most surgeons aren't excited about taking skin tags off.
They're benign.
They're very benign.
Okay.
But cosmetically may not be acceptable. So sometimes they are taken out.
Well, for heaven's sake, I'm not even going to go there. Okay, good. We got that there. So another diagnosed question from the audience. 16-year-old male. I love it when you guys give us ages and sex. That's awesome. So 62-year-old male, scheduled for a colonoscopy, but having second thoughts. Do it. Just do it. I'm scheduled for a colonoscopy, but having second thoughts. Can I do the fecal occult blood test instead? Okay, Dr. Moraveggi.
We have it ready.
All right,
Okay.
lovely. Go.
Okay, so I have a spiel on this. It might take a while. Do we have time?
Okay, your arms are crossed and
Yeah, I'm
everything.
ready.
Man, I
I'm
got
ready
this.
the whole
And she's
time.
got her notes. See, they
I'm
saw
not
your
going to
notes.
show. No, I'm not going to show 'em. Okay, so first off, colonoscopy is by far the best test, the most sensitive to pick up any lesion versus any of the other tests that are non-invasive. So just to let whoever it is that is contemplating, just like my parents are contemplating colonoscopy and they don't do it still, I would recommend for colonoscopy because then you're cleared for 10 years and you're sure that everything is done. You see the right side of the colon, you see the transverse over here that goes across, and you see the left side of the colon and the rectum and the sigmoid, which is the entire colon. To go back to his question on the FOBT, so the FOBT, yes, he can do it. It identifies hemoglobin in the stool. It can have false positives, meaning your test can be positive if you had meat, if you had greater than 250 milligrams of vitamin C. So these are two things, or a high intake of even meat can cause it to be positive, which then will require him to get a colonoscopy anyway. So those are two things. And the other thing is that you need 3 consecutive bowel movements in order for it to be sensitive enough to pick up a adenoma that's in the colon. So
Adenoma is a polyp.
yes, adenoma is a polyp.
Okay.
I'm sorry. Yes. So
Makes
a polyp.
sense, right.
And the other issue with it is that for polyps that are larger or more advanced, the ones that you're more worried about them progressing to cancer, and FOBT is not sensitive enough to pick those up.
Okay.
So that's one thing. There are other testing methods as well.
Right.
I don't know if you want me to go into that.
Actually, I have a question I think that might be directly related to what you're talking about. Another question from the audience. I have had 2 fecal occult blood tests done. One was negative, the other one was positive negative. Could you please explain what that means? So I don't know if it's I don't know, positive. I know that there's a false negative. Maybe that's what they're trying to say. Or a false positive?
Well, they're going to have 3 different cards. You get cards, and you have to put the stool on them in 3 consecutive days.
Okay.
That's one of the downsides to the FOBT. So maybe one of the cards was positive, and the other one was negative and positive. Either way, any of them, if they're positive, requires you to go for colonoscopy.
Gotcha.
So I don't know if they're saying 1 year I was negative.
That's a great question.
And
I
next
don't know.
year I was positive. It doesn't matter. If you have 1 positive, whether it's the 3 cards, one of them, you still have to go for colonoscopy. You don't want to risk it.
Okay.
Yeah, well, the color might be a tinge off. The color goes blue typically, and this may be a very pale and difficult to tell color.
Okay.
So that could be what they're calling it, sort of iffy. Iffy.
Maybe.
Yeah.
Maybe.
Question for Dr. Mendoza. Let's talk about, and maybe we've, so I'm just going to simply, what is the difference between an endoscopy and a colonoscopy? Beautiful, one end, the other end. So if we can describe that for our audience, please.
Well, technically, by definition, a colonoscopy is a kind of endoscopy. We typically commonly refer as endoscopy to the one that we do through the mouth and look into the stomach and the beginning of your small bowel. A colonoscopy means putting the camera through the rectum and looking at your colon. Outside of those basic procedures, we have procedures called endoscopic ultrasounds that allows us to see your inside organs. Once we put the camera inside the stomach, we can look at your pancreas, we can look at your liver, we can look at your gallbladder. We do all sorts of fun stuff with that camera. We also have a procedure that goes into your bile duct, which is the duct that drains your liver into your intestine. That's called ERCP, and that helps us treating people with stones in the duct that drains the liver, stones in the gallbladder. Nowadays, we started using...
Is that done from the top?
From the mouth,
From the top,
yes.
from the mouth, okay.
We can also use the ultrasound, and I'm just going to use your show to advertise a little bit. We are doing a minimally invasive approach for people with gallbladder problems.
Okay.
That in people who are not a great surgical candidate because they may have underlying conditions that put them at risk of complications, we can drain your gallbladder with an endoscope now. We can remove your gallstones with an endoscope. So that's one of the
literally in the last year, I know three people who's had their gallbladder taken out. I know this is not that show, but you were talking about an event or is this just something that you guys are doing now?
We are doing it now.
Okay.
Yes.
Okay.
This is cutting edge.
Quickly, if you don't mind, and again, I know it's a call-in show, what are gallbladder issues that are symptoms? Are there symptoms to that? Okay, go for it, Dr.
Gallbladder
Mendoza.
symptoms are always pain, mostly under your ribs on the right side. Some people, once the pain has progressed and they didn't really address it, they may get febrile, they may get yellow, they may get nausea, vomiting. The pain usually radiates to the right side of your back just because of the way the nerves are connected in our bodies. Some people may have diarrhea, and if we move even further, if you let the disease progress enough, the gallbladder may burst, and then the pain becomes diffuse, and then you have to go to the operating room.
And then how is that diagnosed? So again, symptoms, because a lot of these symptoms kind of run in together, but...
So the diagnosis is pretty much clinical.
Okay.
Clinical means that we talk to the patient, and the old teaching in medicine is you get this diagnosis 80% from what the patient actually tells you.
Right.
So you get the history, you examine the patient. If you still have doubts or you want to confirm your suspicion, you get a quick abdominal ultrasound, and you'll get your answer right there.
Gotcha. Nicely said. We are at a 15-minute mark, but I want to ask this question before going to that time that we'll say what we want to say. Question here from the audience. So they're talking about monthly bowel cleansing. So we were talking about colonoscopy. We have a nice cleansing first. Question here, is it good either before or after your colonoscopy to have a monthly bowel cleansing? So one question doesn't really have much to do with the other, but in general, I've not heard of that. I know that there's cleanses that people do. Maybe that's what they're talking about. And I'm looking at the young one, because again, I don't think I heard about cleanses until like a decade ago.
I mean,
does anybody want that question?
I saw it on a TV show once, but
you go.
I don't recommend it.
They may be getting into what is sort of a cult thing almost, is high colonic enemas. You can go for a weekend and have some high colonic enemas, clean all those toxins out that have accumulated in the right side of your bowel, and try to sort of detoxify and come back reborn. The trouble is basically that all these bacteria and your microbiota and your whole environmental stuff reform over the next 4 or 5 days. So it really is foolish to do it, and it could be dangerous. That high colonic enema has a lot of pressure. We've had some complications, some trauma to the mucosa. You can drain yourself of electrolytes, particularly potassium. So we would not condone high colonic enemas. We really can't condone that. It is not a way of detoxifying.
Okay.
You better to talk about your diet, better talk about maybe periods of some increased days of fasting. There may be some more physiologic things to do rather than doing that.
Okay. And the beautiful way just to get your colon clean is to get a colonoscopy, because you have the day before of prep, and it gets everything out of your system. So that's another good thing to do. So we're like at the 12:13 mark. So I'm going to stop the questions from the audience for a couple of minutes. And I'm sorry I didn't tell you this, but this is the fun part. Okay. Now we get to talk about everything that we haven't talked about yet, that you really want to get across this evening before we get off the air, because this goes super, super duper fast. Who wants to go first?
Well, let me go first on the irritable bowel, because for our listeners, we talked about a lot of things tonight, but the commonest symptom and the commonest problem in GI is irritable bowel syndrome. 15% of the world has it. It's dominated by females. Actually, 20% of females have it. So when you go to your class reunion, you can chat a bit.
All right.
And find out what the hell is really going on.
We all have to go to the ladies' room together.
All right. So irritable bowel syndrome is extremely common. I want to make sure our listeners know it. Very treatable. Nice. We can't cure it, but we can make your life very much better. Minimize the bad days, maximize the good days. There's great new therapies every day, new discoveries about how the GI tract changed, why you have irritable bowel. And so I would encourage you to don't be concerned about consulting. Please come in and make sure you get educated about irritable bowel syndrome. Extremely common, extremely treatable, but are very much in the world of neurogastroenterology. The nerves of the brain and the gut are very connected here and can make your gut feel very sensitive, painful, and change your bowel habits. We can moderate, modify, and minimize all those symptoms. So I really would give make sure patients feel comfortable realizing how common irritable bowel is and how it can affect daily life, loss of time from work, ER visits. It's everywhere. It's a huge economic burden that needs to be clarified.
And really, I want to talk about, again, where you're going to get your information from. Highly important. So if you're just thinking about IBS, irritable bowel syndrome, you can't go wrong by going to WebMD, because that at least is a peer-reviewed medical site. And again, in the search engine within WebMD, you can look that up so you don't freak yourself out by Dr. Google, as we were talking about. Also, again, the National Digestive Disease Info Clearinghouse is www.digestive.niddk.nih.gov. Again, I'm thinking of the people that are going to watch this again, and you can get that information from there. But you're right, there are so many things that are beautifully treatable. Not curable, but you can treat them, and that's so important for you all to know. So, Dr. Moraveggi, have you enjoyed yourself so far this evening?
Yes, it's
Has
very
it been
fun.
as bad as you thought it was going to be?
No, it's very fun.
Oh, good. Good. So
yeah.
what do you want to tell people that we haven't talked about yet?
So,
or if you want to reiterate something we've already talked about.
Okay. So I think WebMD just in general is good. But if somebody has a diagnosis by a clinician, I think maybe something like PubMed, they can go search their diagnosis, and there's a lot of data on research done, and that would be helpful for patients as well. That's what we use.
So PUB by publication med?
PubMed. PubMed, yeah.
Okay.
I'm not sure if it's .org or what it is, but if they just search Google, Mr. Google, for PubMed, they can find it. So that's another thing. But in general, I guess I'm here to say that everybody should get screened for colorectal cancer. So everybody gets screened for, breast cancer, for cervical cancer. People get their pneumovax, their influenza vaccine, but unfortunately, the United States is kind of behind on colorectal cancer screening. So annually, there's 150,000 new diagnoses, and there's 50,000 people who die a year from colorectal cancer. So it's very important that if they don't want to get a colonoscopy, that they're aware that there's the FOBT that I discussed already. There's other things like getting a CT scan. It's called a CT colonography, which is just an imaging study, and they'll need to be prepped for that as well, but you go home the same day. There's something called stool DNA. So just in general, I want them to know that there's other methods to be screened and to at least be seen by a physician to get an annual physical exam, so that if they're having weight loss or any symptoms, they don't wait too long before it's gone to other parts of their body and they can no longer take care of it, because that's just sad, because we have what's needed in the U.S. to take care of this.
Beautifully said. And Dr. Mendoza, I'm going to talk about what you said earlier, and we were joking about it, but therapeutic endoscopy, that really means you get in there, you provide the therapy, and there's no chance for cancer. So I can't say no chance for cancer, but you know what I'm talking about. Dr. McCollum, you had something you were going to add for a moment.
Dr. Moraveggi's very nice summary is, don't forget, a family history, You would accelerate your index endoscopy to make it much earlier, 10 years usually before the index case in your family. And the recent data is very interesting for the Hispanic population, Catherine. For patients under the age of 50, and we're lowering it now to 45, there's really no markers. Genetic family history does not predict who at age 40 will get colon cancer. You know, Katie Couric's husband was the index case, nothing at all, age 40. And it's more common in Hispanics in the under 50 group. So we're in the right area.
And do we know
about
why?
A low threshold, no data yet.
Okay.
People, bring up diet, bring up this, but we don't want to rely on family history. Hispanic population particularly more prone, under the age of 50 in general. We're having a low threshold to move ahead now and do a colonoscopy. I think the audience needs to know that and needs to be aware, because so far we're at about a 65% screening for over the age of 50. Our goal is 85 to 90%.
Right.
We've got a ways to go in El Paso.
Yeah.
So come on in. The water's fine, particularly if you drink it the day before and clean the bowel out. We want to get above 80, 85, 90% screening over the age of 50. That's our goal.
Right. And I'm hoping I'm not misspeaking here, but I think for insurance reasons, for the most part, I think insurance picks that up because it is in the best interest of the insurance company to get everything cleaned out. So a lot of times that's the question that comes in. I thought I'd address it before that even became a question. Dr. Mendoza, how about you?
So I would just like to echo what they just said. And my take on this is, being that this is March and it's colon cancer month, there are many ways of being screened or tested for colon cancer. The best screening tool is the one that is done.
Beautifully
it doesn't
said.
matter if you're getting a colonoscopy, it doesn't matter if you're getting a stool DNA or you're getting a FIT, which are different kinds of stool analysis we can do. The best one is the one that gets done. We offer a variety of options to the patients. We, as clinicians, as physicians, we know that colonoscopy is just the best one, because if we find something in the therapeutic world, we take it out. And nowadays we can take out lesions that 10 years ago we were not able to, and we were sending them to our friends, the surgeons. Nowadays you don't need to go to the OR. We take them out right there, and you will go home the same day. No need for operations in the abdomen. Technology has evolved quite rapidly in that field. So people need to know that if they have a colon polyp or a lesion, it doesn't necessarily mean they're going to need to have to go to surgery. You can come see us as a second opinion or just as a first opinion, and we can see if we can treat it or not.
So when you say us, is there a phone number that you can throw out there to the world right now? If not, I could just say the Texas Tech University Health Sciences Center. There's the gastroenterology department. Is that correctly said?
Yes.
Or
we can give out the general number of the secretaries and the answering service, 915, obviously, 215-5191, and say that you're calling to talk to a gastroenterologist and or leave your name or number, and we will get back to you diligently and make sure we find a place for you in our clinics and our endoscopy schedule.
Very nice. And again, that number, if you're in El Paso, but if you're in Las Cruces, Juarez, 915-215-5191. And again, this is Texas Tech University Health Sciences Center, and Dr. Richard McCollum, the tummy doctor. That would be quite great. And Dr. Mendoza, I didn't know if you had something else you were going to add. I just wanted to throw that number out while you were speaking.
Yeah, so that's it. And then also people need to be aware that there are other tests available other than colonoscopy. If you're afraid, and we respect everyone's decision, we push for the colonoscopy, but if you don't want it, there are other ways of testing. But just keep in mind that if those come back positive, that means you're going to have to go to colonoscopy anyway. So it's a matter of negotiating with what your interests are, what you're afraid of, and we can find a solution, and we need you to get screened. That's the message that we need to convey to people, is you need to be checked.
Exactly. You need to be checked. And I love how you said the best screening tool is the tool that you have, the one that you used. We're only on 4 minutes left to go, but we have not talked about inflammatory bowel disease. I know we talked about irritable bowel disease. Is that similar, one and in the same? And I know I want to just touch about it quickly, because we've got a whole section on this that we didn't touch.
Well, I can start. Dr. Mendoza Ladd is one of our experts. If the camera could just show our diagram here, we have two conditions. One is ulcerative colitis, where the whole bowel is red and raw and has degrees of bleeding and ulcers. And there's another section called Crohn's disease, typically more in the small bowel, where we have linear ulcers, which can also look very nasty.
Sorry about that. Apparently that's been going on in the studio all day.
So 2 types of colitis, Crohn's disease and ulcerative colitis are the 2 types. And Dr. Mendoza-Ladd sees a lot of this as well, and he may have some comments about the pros and cons of those 2 entities.
Okay, and I'll stop just for a second because I need to acknowledge the obvious here. Before this show came, there's a lot of people in this building that went home today because this fire alarm kept going off. It's not real.
All right.
So I want everybody in the studio to know it's not real. I want everybody at home to know this is a fire drill. If it was real, we'd say see ya. It's very annoying. My apologies. Thank God it's at the end of the show. So, how many? Okay, so the guys that have been here all day today, is this go on for like 5 minutes? Is this pretty? Okay.
Maybe we can answer another question.
We're going to ask one more question. Diagnosed with diverticulitis, and they rushed to have surgery. Now they said that it's dangerous if they don't get treated right away. They took out half of my colon and the small intestine. Is this normal for them to take out? Question from the audience, and it's loaded. I'm so sorry, and we have 2 minutes.
Typically, the answer would be for diverticulitis, we would not take out the small bowel unless there was an abscess that encompassed or entrenched or incorporated the small bowel in the problem. So, unusual situation. I wonder whether the patient may have had what's called Crohn's disease as well, but that's not straightforward treatment.
Okay. I don't know if we can end the show early since we only have 2 minutes, but I think we may end up doing that because I'm sure this is driving me crazy. I don't know if people can hear us. But let me once again say, Dr. Richard McCollum, thank you, because you not only showed up today, you actually are a sponsor of this program, because I know how you love getting information out there, and it matters so, so much. Dr. Sherry, and thanks for having an easy first name. Morajevi, thank you for coming. I'm glad that you made it, and I'm glad that you got through your first show because now you're a veteran. Dr. Mendoza, thank you so much for being here. And again, the numbers to call could be cancer.org. That is a website. That's the Cancer Society. And again, www.pub.med.org or .com. And again, the number to the clinic, 915, yay, 215 5191. God, it's like taking a bath. That's bath salts and everything, but we so appreciate you all being here. Again, you've been watching the El Paso Physician. You can watch this again on kcostv.org. Just look up the El Paso Physician under Watch and under Programs. You can find that there. Also under the El Paso County Medical Society, that's epcms.com. And you also, if you are a Facebook user, you can look up KCOS TV and then find this again on Facebook. It will run for the next couple of days. And as far as these other 2 websites, they'll be on it very soon. Thank you for watching the El Paso Physician. I'm Catherine Berg, and we bid you good night.